Hey everyone, thank you so much for joining us tonight. My name is Brandy Thomas and I'm the producer for Texas Fertility Center. Today we've got Dr. Lisa Hansard. She's going to be covering all sorts of great things for LGBTQ couples, everything pertaining to infertility. But before I bring her on, I wanted to go over a little bit about how this webinar is going to work and just a few other things that we've got coming up. So first off, Dr. Hansard is going to be talking for about 45 minutes, and at about 15 minutes, she's going to stop to answer questions. If you look to the side panel, there's a place to submit questions, and they're all private. Nobody can see your question. So feel free to ask away, and depending on how many we get, we may not be able to get to all of them, but we will try to get to as many as we possibly can. And then she's also going to be stopping to answer questions at the end of the webinar as well. So that'll just be a good opportunity for you guys to kind of engage and Dr. Hansard to share all the information that you guys need. In addition, this is actually part of a monthly webinar series that we do. We cover a variety of infertility topics, and we're actually going to be doing another LGBTQ webinar in the next few months. So we do encourage you, invite friends or anyone you think that would benefit from this information to our next one. And you can find information about that either on our website, which is txfertility.com, or we'll be sending you an email. Since we now have your email address, we will send you an email and let you know when we're going to be doing the next one. But I think that about covers it. So with that, I'm going to go ahead and bring on Dr. Lisa Hansard.
Hey, everybody. My name's Lisa Hansard. I'm one of the fertility doctors at Texas Fertility Center in Austin. I have actually been in this practice for 24 years. And I started the third-party reproduction division of our practice in 2004. So this is something services that we've been offering to people in need of donor services, gestational carriers, donor eggs, donor sperm. So today we're going to talk about fertility options for the LGBTQ community. And this obviously is a large group of people who have different needs, from same-sex female couples to same-sex male couples to situations where a female couple wants to have one of the partners donate eggs, the other partner be the carrier of the pregnancy, what we refer to as reciprocal. And we can go into detail about that. But first of all, I think the best thing to talk about is what does it look like for the most common treatment, which is donor sperm insemination. So when we talk about sperm donors, we really talk about two different categories of individuals. One are known sperm donors, so someone that is close to you, friend of yours, etc., that you would like to share genetics with. The most common type of sperm donor would be an anonymous sperm donor. So we're going to talk a little bit about the differences in screening and what the legal ramifications of choosing one or the other are, and some of the pitfalls that you can encounter if you don't do your homework and don't follow the guidelines pretty strictly. So when we talk about the qualifications for sperm donation, there's really two aspects to this. One is, what does the FDA say? So you might say FDA, that's the Food and Drug Administration, right? So what do they have to do with any of this? Good question. The FDA is actually the part of government that is tasked with donated tissues, cells, blood, etc. And their main focus, their only focus, is on reducing the risk of transmission of communicable diseases. So there are certain things that are statutes, regulations. This is a law. These are the rules you have to follow. And anonymous sperm donation falls into that category. So every sperm donor, an egg donor for that matter, is screened for infectious diseases, including HIV, hepatitis B, hepatitis C, gonorrhea, chlamydia, syphilis, and so on. So that's their limitation. That's what they care about. Then there are other guidelines that most of the reputable sperm banks follow that say what else is important in considering what type of person qualifies to be a sperm donor. So these things are going to be more focused on lifestyle, on medical history, on genetic background, on social history, in other words, smoking, alcohol use, drug use, etc. And then there's also obviously the psychosocial ramifications to make sure that you're not inadvertently choosing a donor that has a undiagnosed mental illness. So for a donor to be accepted as into the pool, he has to go through a bunch of testing besides just the infectious disease screening. So a sperm donor has to go through a medical history. There's usually criteria in terms of height, weight, physique, etc. And then he has basically a profile that he fills out. He has screening for illicit substances, and he has genetic carrier screening. And what that means is he gets tested for, it depends on what sperm bank you're looking at, but anywhere from 10 to 300 genetic diseases that he might be a carrier for. This is important because if a woman who wants to utilize a sperm donor, and she's going to be the one who becomes pregnant and uses her egg, then we need to be sure that she's not a carrier for a genetic condition that he's also a carrier for. Because if you have two copies of the gene, what that does is it dramatically increases the risk of having a baby who actually has that disease. And I'm talking about things like cystic fibrosis, muscular dystrophy, sickle cell disease, Tay-Sachs disease, some of these conditions that are either fatal or have a significant impact on the health of a child. So that's one of the things that we look at very, very carefully. So that's basically what's involved in screening a donor. Once the donor, the most important thing, he needs to have a normal semen analysis. So he may be perfect, but if his sperm count is terrible, he's not going to be a great donor. That seems kind of obvious. Sorry, I left that one out. So let's say that a donor goes through the whole process and he is qualified from screening to become a donor. He collects a sample, and that sample, depending on what the counts are, so we're looking at the concentration of the sperm and the motility of the sperm, that specimen is going to be divided up into multiple samples from that one collection. That's the way that the sperm banks make money. So they want somebody who has a really high sperm count so they can take one sample and divide it up to 3 or 4 different specimens. So, and they're going to charge individually for those. So for most people who are seeking assistance using a fertility specialist, we're going to say we need that sperm prepared for intrauterine insemination, IUI. The other ways you can get sperm is intracervical insemination or assisted reproductive technology if you know that you're going to be doing in vitro fertilization. But for now, we're talking about going to the doctor's office and having an insemination. Once these men have qualified, they've collected a sample, that sperm is frozen and quarantined. What that means is it's not going to be released for use for at least 6 months until that man goes through the infectious disease screening again, and he is still negative for all of those disorders or diseases that I talked about. Once that happens, then the sperm that was collected 6 months ago can be released. So that's an FDA regulation that is very, very consistent through all of the sperm banks. So you can be pretty confident that if you're looking at different sperm banks and trying to compare, the ones that are reputable, that have been around for a while, this is the way that they are screening their donors. Okay, so a known donor, that's a totally different ballgame. So there have been situations where men have been chosen to be sperm donors without really any background. So a semen analysis hasn't been done, infectious diseases screening hasn't been done, there's no legal agreement, and that can really turn into a bunch of problems. So if you have somebody that you absolutely think this is the person I want to be my donor, I'm not interested at all in, a sperm bank, I want to go this route, it's still best to meet with a fertility specialist like one of my partners at Texas Fertility Center to make sure that all the rules are being followed and that you're going to be protected. And that includes the same type of infectious disease screening, the same type of genetic carrier screening, as well as having some kind of a legal contract in place with that person. All right, so that's the donor. Let's talk about what happens on the female side for someone who wants to become or wants to get pregnant utilizing donated sperm. So for couples who are heterosexual, who are having regular unprotected intercourse, typically we will not start any type of an evaluation until they have had 1 year of unprotected intercourse if she is under 35, if the female partner is under 35, or 6 months of unprotected intercourse if the female is over 35. Well, in this situation, that isn't really possible because there is no sperm exposure prior to this. So we take the steps in the beginning of making sure that there are no identifiable fertility issues in the female before launching into treatment. So what that would include is the genetic carrier screening that I talked about, infectious disease screening for the female and for her female partner. The reason this is important is because obviously the FDA is doing everything that they need to do to protect the females from being infected. But at the same time, if something, heaven forbid, were to come up months down the road and you end up with hepatitis or, chlamydia, it's very important to be able to go back and say, on this day, my partner and I were both tested, we were both negative, and the only thing that's happened in the intervening time is we had a donor sperm insemination. So at least we have some kind of accountability there. And I think that that's very important. The other things that are important are to look at the status of immunity to a very common childhood infection called CMV. It stands for cytomegalovirus. So if you looked at any of the donor websites, you may see on them, they say CMV positive or CMV negative, and you may not know what that means and why it's important. So CMV is, as I said, a very common childhood infection. A lot of us had it, and it would have just presented as maybe a fever and a rash, like a lot of viral infections in children. The problem with CMV in an active infection in someone who becomes pregnant is if a woman is infected in the first trimester, the first 11 weeks of pregnancy, there can be significant impairment on the neurologic development and particularly deafness. So that's one of the most common causes of non-genetic deafness in the country, in the world actually. So it's highly unlikely that the virus could be transmitted through semen, but it is not impossible. So we're always going to ask our patients to get the status of their CMV immunity. If they're immune, meaning they've been exposed to CMV in the past, then there's no problem with picking a donor that is also has also been exposed to CMV in the past and is immune. If, on the other hand, the recipient, the patient, is CMV negative, then it makes more sense from a safety perspective to choose a donor that's also negative. So when women come in or couples come in and they say, hey, we've been looking at all these donor sites and we think we found our donor, I always say, like, tap the brakes, because don't get your heart set on this donor. He may not be a good fit for you, because he may have a genetic abnormality or a genetic mutation that you also carry, and the CMV status may not match. Okay, so that's it on choosing the donor. The other thing that we're going to do for a female is we're going to look at your ovarian reserve. That's a term that refers to quantity and or quality of the eggs that a woman has. So for most women, not most women, all the eggs we were ever going to have, we were born with. And as we go through our reproductive life, we use those eggs, and oftentimes the ones that are left as we get older are not as healthy as the ones that we had when we were in our 20s. So it's going to be important to look at that. That tells your physician if we need to look at any other fertility enhancing measures on your side. In other words, do we need to use some kind of ovulation enhancing medication? Do we need to use a medication that's going to potentially result in releasing more than one egg for a higher chance of fertilization happening? The other thing that we're going to look at is detection of ovulation. So your doctor's going to say, I want you to use an ovulation predictor kit, the ones that test your urine that you can get, on Amazon or at the drugstore, just to make sure that you can determine when in your cycle ovulation is occurring, because that's how we typically time an intrauterine insemination. And the next thing we want to look at is to make sure that the uterine cavity is normal and the fallopian tubes are open. That's usually done with a study called a hysterosalpingogram, HSG for short. It's done by the radiologist at a specific time in the cycle, which is usually after the period ends, but before ovulation occurs. And we just make sure that the anatomy is normal. So once you've had an exam with your physician, an HSG, you've done the infectious disease screening, you've done the genetic screening and CMV status, the final thing is we have you meet with a licensed mental health care professional who's well-versed in third-party reproduction. And this is a guideline that is established by the American Society of Reproductive Medicine, which is our professional organization of fertility specialists. And the idea is to make sure that you have thought out very clearly the issues of disclosure, the issues of ID option at the age of consent, and that there are no underlying reservations or other issues that need to be explored before launching into this. So I've been talking for 18 minutes. I'm going to go ahead and stop quickly for a break and see if we have any questions over what we've discussed so far. Brandy, do you have anything?
Yes, we do. All right. So the first question is, just to clarify, the full spectrum screening for a sperm donor is required for both a known sperm donor and anonymous donor. Is that correct?
The infectious disease screening is a requirement for the FDA for a known donor, and it has to be done in a similar fashion as for an anonymous donor. The difference is, and this is where it gets expensive and tricky, if you don't want to go through a 6-month quarantine of the sperm, you want to be able to use sperm fresh, then the donor has to have the infectious disease screening done within 7 days of every single collection. So that gets expensive because the cash price through our office for FDA infectious disease screening is $275. So that's an added expense every single month if you don't want to freeze sperm and quarantine it. The other things like the genetic carrier screening, that can be waived, but it's a risk. It's certainly not something that I would advise. And the psychological evaluation of the donors is probably also something you would not want to waive, nor the legal consult. We don't treat women who are using a known donor without a legal consent in place.
All righty, we'll move on to the next one. And some of these you may have already addressed,
Okay.
but so we're just I'll try to do as many as we can that haven't been addressed. So what is reciprocal IVF?
Okay, so reciprocal IVF is really the next step. So I think we've kind of covered donor sperm insemination, at least the basics. Reciprocal IVF is when a same-sex female couple wants to share this experience and have one of the women be the donator of the eggs and the other partner be the one who carries the pregnancy. So everyone has a part of this, and they're utilizing donor sperm, either anonymous or known. So with reciprocal IVF, sometimes couples come in and they're very clear on, I want to be the donor, I want to carry. And sometimes it makes sense and sometimes it doesn't make sense. I'll give you an example. We have a couple who comes in and the person who wants to donate is 42 and says, well, I'm going to be the donator because I've got this medical condition, I shouldn't be pregnant. Or she's like, I have no interest whatsoever being pregnant. And the other partner is younger and they say, well, we'll do it this way because, I have a healthy uterus, I don't have any medical problems. I think I would be, do well being pregnant. The problem with that is that the person who is donating, if she's in her 40s, is much less likely to have healthy eggs that would result in a pregnancy. So a lot of times what we end up doing is an evaluation of both partners simultaneously, where we're looking at not only ovarian reserve, but we're also looking at overall general health, who has a healthy uterus, what makes the most sense. So this is something that your doctor will talk to you at great length about to really assess what the best route is. Because that treatment, that particular treatment, reciprocal IVF, involves in vitro fertilization. So all of a sudden, the price tag, the financial and emotional investment in that treatment is going to be much, 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 much greater than if you were just doing donor sperm insemination.
All righty, so we'll move on to the next one. Does IUI with donor sperm always work, and when would it not?
Okay, so that's a great question. That's like saying, does everyone who has sex end up pregnant? And the answer is no, unfortunately. So if we look at statistics let's base this to the general population, those couples that are going to get pregnant, that are having, heterosexual intercourse, and they're never going to end up seeing someone like me. What's normal? What's average? What's considered baseline fertility? What we see is that within 3 months of stopping contraception and being intentional about timed intercourse, about 50% of couples get pregnant within the first 3 months. After 6 months, it's about 75%, and after a year, it's about 85%. If you look at what the chance of conceiving is on a per month basis, it's about 20 to 25% in the first 6 months and maybe 15 to 20% in the second 6 months. So what I always try to stress to patients is, what happens if you're having sex and you don't get pregnant? We just try again the next month, right? This is a little bit different because you have to be so intentional and it's not free. So you have to be patient and you have to understand that you're not going to do better than people who are getting pregnant organically, and it's not going to be higher than 20% per month. So whenever we start a treatment with a couple, we say, okay, we're going to do this. Our plan is going to be, we're going to try this for 3 months. If it doesn't work, then we're going to reassess and say, what do we need to do differently? Is there anything else we can do to enhance the chances?
Alrighty, we got one more here. Is it true that people who use donor sperm are statistically more likely to have a male child?
That is not true.
Okay. All right, and it looks like, so we got time to do one more. And just a reminder to anyone who hopped on the webinar late, we have a questions panel on the right side where you can submit private questions. So we're doing a question section right now, and we'll do more questions at the end. So I'll do one more question. What is ID option?
Okay, so this is something else that you may see when you're looking at the sperm banks and their donor profiles. You may see that it says ID option yes or ID option no. And what that means is that that donor has consented to contact by any offspring that have been achieved through the use of his sperm at the age of consent, which is 18. So this is another reason it's really important to have a conversation with a licensed mental health care professional, because that's not always what a couple wants. You've got to think about, is this in the best interest of my child? If I choose an ID option, no, what are the ramifications of that? If I choose an ID option, yes, what does that mean? So that's one of the things, and one of the main reasons that meeting with a therapist ahead of time is really, really important.
Okay. Do you want to do any more, or do you want to save these other questions for the end?
Let's save those questions for the end, because I do want to address very briefly. I'm kind of looking at the folks that we have on the panel. I do want to talk about situations where an egg donor or a gestational carrier may be necessary and what that looks like. And this is specific to really same-sex male couples who need fertility care. And when I see these gentlemen, often they come to me and they say, well, we think we have a gestational carrier, we're working with this agency, and we think we may have an egg donor or a frozen egg bank that we're going to try to get eggs from, and what does that mean? The issue with all of this is, guess what? You have to have the exact same screening. When we talk about third-party reproduction, that encompasses egg donors, sperm donors, gestational carriers. The FDA is still going to be very involved in, again, the reduction of risk of transmission of infectious diseases. So if you know anybody in this situation, or if you're in this situation where you're looking to start a family as a single male or as a gay couple, then the best thing you can do is go to a fertility clinic first, because many clinics like mine will have kind of one-stop shopping, where we have egg donor option as well as the gestational carrier option, and it's all rolled into one, where we can do all the testing, all the screening, all the procedures, instead of having multiple different entities involved that ends up costing a whole lot more if you're having to do it that way. So that's something that I think is really important to know, that start with a fertility clinic instead of starting with a surrogacy agency.
Okay, great. So did you want to save the rest of the questions for the end?
No, I think that we can go ahead and ask some more questions.
Okay, great. Let's see. So what is the process to freeze eggs when my trans boyfriend has just started testosterone?
Great question. So ideally, freezing eggs should be done before any type of hormone therapy is begun. So I can tell you at least half a dozen individuals that have come in and say, and I'm trans, I want to go ahead and freeze my eggs for later use in my partner. So the process for egg freezing, again, should be before testosterone therapy is initiated, because that can have a negative effect on the quality of the eggs. So an egg freeze scenario basically is like the first part of an IVF cycle. So what happens is injections are self-administered of a fertility hormone called FSH, follicle stimulating hormone. What that does is it stimulates the ovaries to grow multiple eggs at the same time. So when we go through this process of monitoring and retrieving eggs, we're going to try to get a large number that all are mature at the same time. In a natural cycle or a spontaneous cycle, we only produce one egg. So for IVF to be successful, reasonably successful, we need a group of eggs that are all retrieved at the same time. So what happens is the injections are given on a daily basis, self-administered with tiny little needles, kind of like diabetics would take their insulin. And about every 3 days in this process, which lasts roughly 2 weeks, about every 3 days, in addition to having a blood draw There's also an ultrasound to monitor the growth and development of the follicles. So typically in the stimulation process, there will roughly be 3 or 4 follow-up exams. They're 15 minutes each. They're done through the vagina. And once those eggs are mature, based on their size and based on the estrogen level, a final injection is given called a trigger shot. And that triggers the final maturation of those eggs. Exactly 36 hours after the trigger shot, an egg retrieval is performed. That's done transvaginally under ultrasound guidance with IV anesthesia, utilizing an anesthesiologist. The whole process takes about 15 minutes. That is the only day during the whole process that the patient can't work because there's been an anesthetic. Then the embryologist will assess the eggs. They'll determine the maturity of the eggs and how many could be frozen. Once that happens, we go back and look at data and tables and graphs that say, okay, at this age, with this many eggs frozen, we can then determine what the probability is of being able to be successful in having a pregnancy in the future. For instance, if you're under 35 and you have 12 eggs that were frozen, that's going to give roughly a 60 to 70% probability of having at least one live birth, and maybe a 30% probability of having 2 children out of that batch of eggs. That's a good question.
Perfect. Okay, so we got the last question here for this section. All right, we are a same-sex female couple, ages 30 and 31. Are there any particular steps we should take before making our initial appointment with Texas Fertility Center? We have not looked at donor banks, etc.
No, that's a great question. A lot of times women will start with their OBGYN and they may share the same OBGYN, they may not. It's a whole lot better to just come to us and to let us lay it out. We know the diagnostic steps that are involved. We know FDA regulations. We know all the guidelines from the American Society of Reproductive Medicine. So it's always amazing when I meet a couple and they're like, okay, we think we want to do this. What are the steps? And I say, it's very straightforward, especially if we know who's going to be carrying. And, you know, it's a straightforward situation for donor sperm insemination. Literally within 1 menstrual cycle, we can do every single bit of the testing, have the psychological evaluation completed, be ready to choose the sperm donor, and the very next month be able to attempt pregnancy. So wasting time doing things piecemeal with a gynecologist or a primary care physician, things are going to be missed. You're going to end up needing to repeat things, and it's not going to be as efficient as if you just start with a reproductive endocrinologist.
Great, so I think that wraps up the questions for right now. And again, to everybody on here, you're welcome to ask questions and we will answer some more at the end.
Okay, great. So I want to talk about reciprocal IVF in a little bit more detail, just so that we understand exactly what's involved. So let's take this couple, for instance, that Brandy just mentioned. So 30 and 31. And this couple comes in and they said, okay, you know, maybe we both want to be pregnant, but we want to do this where we're sharing the experience each time. So what we would do in that situation is we would start by doing ovarian reserve testing on each of the female partners. Ovarian reserve testing is the comprehensive one that we do. What happens is at a specific time in the cycle, which is usually cycle day 2 or 3. So when you say my first day of full flow is cycle day 1, on the 2nd or 3rd day, we send you to the laboratory to get this battery of hormone tests. There's 5 different hormones that we look at: LH, FSH, estradiol, inhibin B, and AMH, anti-Mullerian hormone. All of these hormones are involved in ovarian function. We use a reference laboratory that takes these values, plugs it into a software program, of course, and generates a number between 1 and 20. That's called the Egg Retrieval Score. And it basically is going to approximate the number of eggs we would get if we were doing an IVF stimulation, okay? And in addition to giving us that score, it also says in your age group, where do you fall? Are you average, above average, below average? So let's take a hypothetical couple that we were talking about. So they're essentially the same age and they both want to be pregnant. They're going to pick the same sperm donor so that their children are genetic siblings, half siblings. And what we're going to do is we're going to say, okay, if nobody cares who goes first, we're going to look at the person potentially who has the lesser egg retrieval score, the one who looks like she has a lower ovarian reserve than the other, okay? And she's going to go through a stimulation first, and she's going to create embryos, and we're going to have those embryos. Let's say that she's actually the one who wants to be pregnant first, but she wants to use her partner or her wife's eggs and a sperm donor. That's perfectly fine because she's put her embryos on ice. They're there waiting for when her partner is ready to be pregnant. Okay, now the other partner goes through a stimulation, exactly like I talked about for the egg freeze for the trans boyfriend situation. So she goes through a stimulation, egg retrieval, creates embryos, and now we're going to get the first partner ready for pregnancy. That's a pretty simple thing. So we've got embryos already, and they are frozen at a stage which is what we call a pre-implantation blastocyst. So this is an embryo that would typically get to the uterus from the fallopian tube, ready to implant into the wall of the uterus about 5 days after ovulation. So we can either prepare the person who's going to carry with a medication to induce ovulation and then just time 5 days later, or we can do a different type of preparation where we just use estrogen to grow the lining and progesterone afterwards. But this is a very simple thing to do to be able to coordinate it. A lot of times couples come in and they're like, I'm very, very confused. Like, how in the world are we going to be able to time her ovulation to when the uterus is going to be ready for an embryo? And I just say, you know what, this is what we do every day. So it may seem complicated to you now, but it's really not that difficult in practice. In that situation, though, not only would we do ovarian reserve testing on both partners, we would also do the genetic carrier screening, the CMV status, so we can determine that the donor that they choose is going to be an appropriate match for both of them. So I think that's important when couples are deciding, okay, we're going to do this, and maybe my partner's going to get pregnant first, and then I'm going to get pregnant second, but we definitely want to use the same donor. If that's the case, both partners need to be tested at the same time early on before donor selection is made. I actually will tell you, I have a patient, a couple, a lesbian couple right now, and they are both pursuing donor sperm insemination at the same time. Now, one of them already has a couple of kids, and so she knows what it's like to be pregnant and the hormones and kind of the needs that you have from your partner. The other one's never been pregnant before, and she thinks this is going to be the most fun ever. So it's been really interesting to see the dynamics of the two of them. So there's really not very many scenarios that you can think of that we haven't dealt with and approached at a very, with a very logical manner, but kind of everything is possible. The other thing that a lot of people are gonna ask about, they always ask about, is the cost. Like, how expensive is it to do this? And I'm going to tell you that I can't really speak to the cost of sperm because every sperm bank's a little bit different. And kind of also, you may pay extra if you choose the ID option. That may cost a little bit more, but in general, a vial of sperm is typically around $1,000. So let's say that you are in that best situation where you've done all your testing. Most insurance companies will cover fertility testing in Texas. Most of them don't cover, none of them cover the cost of the sperm, but they will cover the actual treatment depending on the policy. But almost all of them cover the diagnostic testing. So that's good to know that all of the things we talked about doing at the front is usually a covered benefit. But let's say that you're someone who's just perfectly fine and everything's normal and ovarian reserve is good and cycles are regular and an ovulation predictor kit works for you and you can say, yes, this is the day I'm ovulating. It may be as simple as having the sperm shipped from the sperm bank. And that's another question that people ask all the time. How much sperm should I get? And I always say, well, I don't know, if you're in Vegas, how lucky do you feel? It's like, how many times do you think that this is going to take? But we definitely like to have 2 vials of sperm for an insemination. And the reason is most of these sperm banks are going to guarantee a total number of motile sperm for that particular sample. So most of them will say, we guarantee that when this sperm is thawed, there's going to be at least 10 million motile sperm in that sample. So when our andrologists thaw the sperm, they're actually going to do a count. And we're going to get that as part of the information on the day that you have the insemination. Let's say, for instance, they thawed a sample and it was terrible. The sperm count was, 1 million. The motility was terrible. If we have a backup sample, then we can go ahead and not lose that cycle. We can thaw that second sample and we can do the insemination. Now, you have recourse because you can say, you didn't meet my guarantee, and they will usually either give you a refund, especially if you got pregnant that month, you would just want a refund, or they will replace a sample that did not meet criteria. So that's also very, very important to know. So in terms of the cost, sperm costs may be around $1,000 per vial. So you've invested, let's say you said, we're going to try this at least 3 or 4 times. So we're going to get 4 vials of sperm and see how we go. So that's going to be about a $4,000 investment. Now, when you come to our office, to TFC, there's going to be a sperm thaw fee that's around $100. And then there's going to be the physician fee for doing the insemination, which is probably around $200. So all in, you're looking at somewhere around $1,400 or $1,500 for just a natural cycle ovulation predictor kit. If you start adding other treatments to that, like I'm taking injectable medications to get 3 eggs to ovulate, or I'm using an oral medication and I need a trigger shot, or I'm having to have ultrasounds for monitoring, each one of those is going to add the expense of whatever that treatment is. So it may be something where $2,000 if you're going to do a medicated cycle with an oral medication and donor sperm. It can go up to $3,000 if you're doing an injectable cycle with donor sperm. If you're talking about reciprocal IVF, in vitro fertilization, there's a very, very wide range depending on how much medication is required, whether or not you choose to do chromosomal screening of the embryos, etc. But you can very easily spend $15,000 to $20,000 all in for that treatment plus the embryo transfer, either to you or to your partner. So those are things to think about when you're also looking at how do you plan for this financially. And on that note, I'm going to continue with this. We have a few more minutes. We can talk about this. A lot of people come to us, not just, in the LGBTQ community, but our other patients as well, and say, my insurance doesn't cover this. This is expensive. How do people pay for this? And we have different organizations that we work with that provide low interest financing for elective medical procedures, and this falls into this. Some have these package deals where, particularly if you're doing IVF, you get 2 cycles plus a transfer for X number of dollars. I think the better options are to just look at low interest financing. So to say, we're just going to say we need to borrow X number of dollars for medical care for this particular treatment. What's the finance, or what's the interest rate that we're going to be charged? It should be pretty sweet right now. So that's another thing that that's a consideration. Brandy, are there any other questions?
Yes, we do have one that just popped up. In your opinion, what is the most invasive / uncomfortable part of the IUI and the IVF process?
Okay, so that's a really good question, and they're both really, really different treatments. So for IUI, it's not uncomfortable other than it's a speculum exam, like when you go to the gynecologist to have a pap smear. So an IUI is really, really minimally invasive. Basically what we do, knowing the day of ovulation, when that's occurring, we place a speculum, we kind of clean off the cervix, and then we have the sperm in a syringe with a very thin catheter. We thread that catheter gently through the cervix and deposit the sperm up at the top of the uterus where the fallopian tubes come in. So that is no more uncomfortable than undergoing a pap smear for your annual exam. IVF is a different story. There is no real procedure with IVF that is uncomfortable, because the actual egg retrieval is done under anesthesia. So you're asleep for that. It's not uncomfortable at all. But the most uncomfortable part of IVF is, since we are specifically trying to get multiple eggs to ovulate and develop, the ovaries are going to get larger, and there's going to be lots of activity in those ovaries. And women say, I feel like I'm carrying around 2 grapefruits in my pelvis, or some people say, I feel like I'm carrying around 2 bowling balls in my pelvis, just depending on how that goes. And after the egg retrieval, since those ovaries are enlarged, there can be some bloating and fullness and some discomfort that we always provide pain medication for if necessary. But the 2 procedures are really, really different. But that's a very good question.
All right, and up next, I've had an IUI with donor sperm at my OBGYN, and it really hurt. Is this normal?
Okay, so this is very common. The way that I look at this, and I'm never going to say anything negative about OBGYNs, because, God bless them for what they do. And I guess I'm technically one of them as well. But it's all about kind of experience, and what do you do if there is a cervix that's not super straightforward. This is what we do all day, every day. We know all the tricks, and we know how to make it not hurt. There's some OB-GYNs who always use an instrument called a tenaculum, which is basically like a clamp that goes on the cervix to straighten it out before they do the IUI. That hurts like terrible. So that is something that, I can't even think of a time when I've had to resort to that. We have other ways that the cervix is being difficult. We have other ways we can switch catheters to very thin, flexible catheters that can kind of make those curves along the way. But it's very, very uncommon for our patients to say that an IUI was uncomfortable. The most common thing that happens if someone has been to their gynecologist and had an IUI, when they come to us, we do the IUI, we finish the procedure, and they're like, wait, are you done? Is that it? Did you already do it? Because it's just, it's for us, it's second nature. It's what we do every day. And for gynecologists, it may be something that they do once every, month, or once every couple of weeks. So a lot of it is just about having the experience with the technique.
Okay, let's see. Okay, so we have a couple of questions about scheduling appointments that I'm going to save for the very end, and I want to get to one more technical question here. Okay. Do you have an opinion on doing insemination at home, like the turkey baster method?
Yes, I have an opinion, because I think most of the time when people are doing that, they haven't been through the recommended channels and guidelines, and it just makes me very nervous about what they're gonna, potentially encounter. The other thing is that unless you have a medical background and really understand the nuances of um, ovulation predictor kit and charting and making sure that the luteal phase is normal and doing the full assessment. Women who are doing at-home inseminations usually haven't had the test that I'm talking about. They're like, we're just going to try this. And again, same thing I hear all the time. Women come in, they're like, well, we tried, 4 at-home inseminations. I'm like, okay, so let's kind of backtrack and let's talk about what you did. Now let's kind of catch you up on the diagnostic testing. And it's very common that we determine that either the timing was completely incorrect, or, oh, look, we did this dye study and you got a blocked tube, or some other factor comes up. And it's mostly what they say is, I wish I would have just come here first.
Okay. Once a pregnancy occurs, do we move on from TFC to an OB, or does TFC continue with us through the birth?
So we don't, because we don't practice obstetrics, but what we want to do is make sure that the pregnancy is viable and ongoing. So we are kind of freaks about how we monitor pregnancies early on, because it's all we do. Again, this is what we do. So it's not just, oh, you did a urine pregnancy test and it was positive. Well, we'll see you in 3 weeks for an ultrasound. This is a pregnancy that's taken a lot of investment, financial, emotional, physical investment to achieve this pregnancy. So we are very, very involved with making sure that everything is going well. So we will tell you exactly 2 weeks after the insemination, if you haven't started a period, we want you to go get your blood drawn. We're going to check an HCG level, which is the pregnancy hormone, not just plus or minus, but the actual quantitative level. And if you're pregnant, we're also going to check a progesterone level to make sure that's adequate, because a low progesterone level can be a risk factor for miscarriage. So if it's low, we'll go ahead and start supplementing with extra progesterone. And we'll follow those levels to make sure that they are increasing at the rate that they should be. And then exactly 3 weeks after the first pregnancy test was obtained, we do a sonogram. You're technically 7 weeks pregnant at that point. We can talk about how the math is done later, but at 7 weeks, we ought to see a fetus with a heartbeat. If we see that, and we've got a good strong heartbeat, a fetus that's measuring the right size, at that point, we're going to say, great, we're releasing you back to your obstetrician. And then everybody's happy. The OB doesn't have to deal with any of the monitoring. They know that the pregnancy is good, and we're passing the patient back to their doctor who sent them to us in the first place. So it's a very, very good relationship that we have with the OBGYNs in the community.
Okay, and it looks like these are the last questions. And there are actually 2 questions that I'm going to combine into one because they kind of pertain to the same thing.
Okay.
Where are your offices located? How much is the initial consultation fee? And how do you make an appointment for a consultation?
Okay, so I'm going to kind of give you different answers for those, because it all depends. So we have 3 offices in Austin. The central office is on Mopac between Far West and 2222 on the west side of the highway. We have a Round Rock location that is located immediately behind Round Rock Medical Center. And we have a South Austin location that is Mopac and Davis Lane, just north of Slaughter. So to make a new patient appointment, we have
I'm so sorry. Dr. Hansard, I don't mean to interrupt. This person actually asked, do you have a branch in Corpus Christi? And so I wanted to make sure that they know that we do have branches.
Okay, yes, we do have a satellite in Corpus Christi, in New Braunfels, and in San Antonio. So the answer to all of those questions is yes. In terms of making an appointment, you call our central line. If you wanted an appointment, for instance, you're in Corpus and you want an appointment, then there's on our website, there's a specific number you call for a Corpus appointment. And that would be with Dr. Hudson. And so she's our Corpus doctor, and she's also in New Braunfels. So she splits her time between there. In terms of making a new patient appointment, you contact our office. If you go to the website, it's going to say make an appointment. And we have a new patient coordinator that will go through your insurance, get all the information, set up an account, etc. Then a couple of days before your actual appointment, you're going to get a phone call from our new patient benefits verification team. And what they're going to do is they're going to call your insurance, they're going to find out what your benefits are, and they're going to call you. It's Robin or Jasmine. They're going to call you back and they're going to tell you exactly what to expect your first visit, what's covered, what's not covered, what your copay is, etc. So I can't tell you the answer to that question because it's going to be different for everybody's different plan. But I can tell you that in the state of Texas, if you have insurance and your insurance is from Texas, that diagnostic coverage is included 90+% of the time for doing the initial evaluation, consultation, and testing.
Perfect. I think that wraps up the questions.
Okay, well, I mean, it also just about wraps up our hour that we had allotted for this webinar. So I definitely appreciate you guys listening in and asking really, really great questions. I hope that I get to see some of you in the office as a patient. It'd be great if everybody plugged into a webinar like this ahead of time before coming to see me. It'd make our visit really, really, we could just talk about, you know, sports or the weather instead of all the medical stuff. But I hope it's been useful to you. And if you have any other questions, I would really direct you to our website, www.txfertility.com. There is a whole section on donor sperm insemination and evaluation and LGBTQ services. So I hope we get to see you sometime. Thanks.